Alex?
Thank you. Um, this afternoon, this is all about understanding why death and dying is everybody's business, and it doesn't just sit in health anymore. So the idea is that by the end of this presentation, you should have a better understanding of how you can apply some of what we're going to present into your practice, to better support the people that we care for, and most importantly as well, their unpaid carers. If we could go on to the next slide, please. We're mindful that this is a really emotive subject, and it's about having the right communication skills in order to be able to have some of these discussions that practitioners feel really quite anxious about. But actually, by not having these conversations, we almost deprive people of the ability to access services that we know are going to make a real difference to their lives. And what is so lovely about having Carly here with me today is a lot of the work we've been doing together is that collaboration between health and social care. What we ask is that today your reflection should focus on a professional rather than personal experience, and that's certainly when you're trying to apply that into practice. And we know that if you can take the time to engage with the process, this can significantly ease the learning journey. So it's about helping you to better understand and imagine your own emotional and developmental needs that are really quite unique when we are supporting people with a life-limiting condition and their unpaid carers. If we could go on to the next slide, please. So, the question of how to live well is an age-old concern. In contrast, the question of how to die well is far less frequently considered. And as social care practitioners, it's really important that we start to open up these conversations when we're completing, whether it's a social care assessment or whether it's an unpaid carer conversation. Because as Carly is going to talk about a little bit later on, it's about understanding when is the right time to be starting these conversations, and what is applicable at the time. So Carly, if we can move on to what is a good death.
Thank you, Alex. So I think when we think about what a good death might look like, we all have our own thoughts and feelings and pictures and images of what that might look like. As we are all individuals as we live, how we die also reflects that. And I think it's really important, as Alex said, to be able to have these conversations so we know and we can prepare for people's deaths, so we can give them the death that they would like. Having worked in the hospice for over 20 years, every death is different, even with the same conditions. Families are often surprised at music choices, at all sorts of stuff that their loved ones may choose. So I think it's really important that we have these conversations and think about what a good death may look like. Now, when we talk about these conversations, communication can be really hard. We sometimes worry that we may trigger or say the wrong thing, and that might provoke an emotional response. So that might often delay, or even we may not undertake that conversation because we don't feel comfortable. We might worry that we're going to open a can of worms and we won't be able to deal with it because we don't know how to deal with that raw emotion. Or we may not have physically the time. We're all very, very busy. So we think, actually, I've only got this long to be with this person. Have I got time to go there? There's also about training, about practitioners feeling confident and comfortable having those training. Social workers, I'm always in awe of you all. You have the most complex conversations about addiction, about housing, about all sorts of stuff. These are all transferable skills here that you have. It's just because the subject is slightly taboo in our culture that makes it harder. Excuse me. I think emotionally, it can be quite hard as well to have these conversations. It can feel overwhelming. We know about compassion fatigue. It can be difficult. Sometimes if we've had our own personal experience, it can reduce people's confidence, capacity. Or on the other hand, somebody may have never experienced death or dying. So don't know the process or understand the process to feel confident to have those conversations. They can be hard as well because there's a lot of unanswerable questions, such as prognosis. We can guess. We're often wrong, but we can have a guess at it. Some questions there are no answers. Why me? All sorts of questions. So sometimes there's a fear of appearing ignorant because we don't know the answers. We may not have the skills to answer these questions. There's a lot of uncertainty. If we then start to look at sort of cultural and religious beliefs as well, staff, practitioners, we all have our own values and experiences in our own workplace, but also in our own life. And some of our own fears, as I said, or cultural norms around dying or talking about dying could also impact how we support the person. I think sometimes there's a concern that we may damage the relationship that we have with people, especially if you've had a long-term relationship with somebody. By having some of these conversations that you might feel you might break, I'll try it again, may break some trust. And as I said, these conversations take time, and sometimes in a really busy, stretched world, we don't have that time. As I said, we treat everybody as an individual always, and I think we need to think and consider cultural differences, especially around end-of-life conversations, and we need to think about that. And that's also really important when we're talking about what a good death may look like. Many cultures hold specific spiritual or religious beliefs, and that shapes how people view death and the dying process. Some cultures see it more as a transition rather than an end. So it's really good if we can understand what their belief is and how they view it. Other cultures believe that actually if we talk about death, it's bad luck and it might actually hasten death. We also need to plan for the end of life. So actually we need to know, so we consider any rituals, last rites or spiritual practices that is important, so we can plan for this to happen. So we can ask gently, what their beliefs are, and we should be guided by them about their care. And we shouldn't make assumptions just because somebody has a certain belief that they will follow a certain path because of their belief. We also know that in other cultures, that some cultures place emphasis on decision making as a family rather than an individual, or sometimes it might be the eldest son that we need to speak to and talk to. We know that some cultures are very open and talk very well about death and the process and how very natural it is. We also need to consider non-verbal communication as well when we're thinking about culture, eye contact, touch, all of that we all need to consider. We also know that different cultures have different beliefs towards pain and suffering and symptom control. There may be concerns about addiction or sedation around some of the medication that we might use. We know that there are certain beliefs in approach to pain relief and about the use of morphine, and some cultures see suffering as a spiritually meaningful. So we need to be aware of this so we can help support.
And Carly, can I add something to that? So we also know that these are questions that we need to revisit, don't we? We know that actually somebody may say, do you know what, actually, I don't have a religion. But actually, as the disease progresses, they may feel very differently about that. And that can go either way, isn't it? But it's being mindful that many things may change over time. And in terms of pain relief, we know sometimes that can cause somebody to be more sleepy. And actually, it's their preference to be more alert, to be able to spend more time with their family. So whereas a lot of people think actually a good death is pain-free, for some people, actually a good death is having that ability to still be able to make further memories and spend time with those people that are really important to them.
Absolutely, and I think we need to consider that for those that are important around them as well. There could be a difference in interests and beliefs as well. I always think of the story, Alex, about the phone calls that you get on the unit from people that are saying, you know, your social practitioners, colleagues out there that say, oh, you know, they're not taking pain relief. We know they're in pain. You know, they should take pain relief. But actually, if that person has capacity and they're making that choice, then as hard as it is for us as social work practitioners and healthcare practitioners to watch that, actually they've got that right to refuse that, and that's a conversation that pops up a few times, isn't it, Alex?
Yes, there's this perception that actually it has to be a safeguarding. And you're right, Carly, as long as we are, somebody is able to understand the relevant information and we don't doubt their ability to make these decisions, actually they have every right to not accept any treatment at all. And I know that you've said before in the past that actually this sits really uncomfortably with our specialist nurses as well and the other teams within the hospice.
Absolutely, because I think sometimes we know we can make somebody more comfortable, but that's not our decision to make. That is them as an individual to make that decision, and support them, but also the people around them, and that might include social practitioners and healthcare practitioners in that decision. So how can we help our practitioners with the end of to prepare for end of life conversations? I think is something we need to talk about, and I think um, we know that people benefit from training. We know that they benefit from communication skills. As I said, I'm always in awe of some of the conversations that I know some of my social care practitioner colleagues have. They're very complex. It would make my toes curl. So actually, you've all got some amazing transferable skills. So, you know, I'm bigging you up in Social Care Week.
Thank you.
I I think there's trying to create that psychological safe teams, isn't it? Trying to create that safe space, that supportive team cultures, allowing staff to reflect, admit uncertainty, be able to talk about any fears, concerns. I think also what we're very good at in the hospice is also being aware of what's happening in each other's lives and go, actually, that maybe that might not be the right time to have this, or for that person to have the right conversation. Maybe I need to have that conversation with that person today. So, and we know that all of that helps build confidence and resilience, having those conversations. And I think, you know, you've got clinical supervision, reflective practice. We recently took part in a Schwartz round here at the hospice in conjunction with Cambridgeshire County Council, all about supporting people's well-being, and that all helps to improve quality of care and service that people provide, making sure that people have up-to-date information. So I would say, as a plea, as a healthcare practitioner, get to know your local hospice. Please get to know your local hospice, or at least visit their website. They have an array of services, of support information, leaflets, how to talk to children, how to support somebody after death, all sorts of stuff, even managing illness before we get to the end stage, breathlessness management, all sorts of stuff. They're a resource. Please look at your local, go and make friends with your local hospices, please. They are lovely, I promise. So
If
that's,
we move on to the next
yeah.
slide. So, Carly, this is where it's really important that as social care practitioners, it's very easy for us to kind of write down somebody's medical history, the different conditions they have. But I would say we don't often give consideration to, is this a life limiting condition? What does this actually mean to the person? And as you're going to talk about now, what is the trajectory of these different diseases?
So I'm going to say that, as I said earlier, we don't always get this right. And also, the people are individuals, so they don't always follow this graph, you know, acute events, and that can happen. So the top line, so we've got function down the side and we've got time along the bottom. So the top black line is a sudden death. So somebody is functioning really well, they're totally independent, they're out and about doing their daily job. They might have an acute event or an accident, and then we have death. So that's immediate. Then we have the blue line that sits just under that, which is a terminal illness. So this is something like a cancer diagnosis, where people have quite a high level of function. So they might have some treatment, they might still be at work, they're still able to do family roles and duties. And then suddenly, as the disease progresses, you'll see them, their sort of function tailing off and time becoming shorter. The orange line is usually organ failure. So this could be heart failure, this could be lung failure, kidney failure. So this is a really tricky one. And this is the one that I think trips up health professionals the most, because we have somebody that keeps going up and down and you think they're going along nicely. And then they might get a chest infection because they've got a chest problem. So you treat them with antibiotics and they pick up again, but they may not get to that level that they were before of function. So then we go down again and then we go up, and it's a real roller coaster. And when we talk to families often with non-malignant disease, with non-cancer diagnosis, they'll go, I've been at his deathbed 2 or 3 times, 4 or 5 times, 6 or 7 times. This is a real roller coaster every time they're preparing for this, their loved one to die. But as I say, they never quite get to the function that they were previously. And then the dotted line sort of at the bottom is frailty. So they may not function as high, but they sort of bobble along the bottom. And again, that can be really hard to determine in somebody that's frail. When are they nearing the end of life? We tend to look at stuff like, are they eating and drinking? Are they mobile? What's their norm for them? What's normal for them? How has that changed and over what time? So as I said, people can do anything at any time, but actually I think it's really good to understand, actually this is somebody who's going to have a high level of function and then might drop off. Because when you're doing you're planning to go back and see this person, you might go, actually, I'm not going to review in 6 months because I know that actually the likelihood of them even being alive is unlikely. So actually I need to do this in a more timely manner. Actually, I need to think that this person, or if I've got somebody with organ failure that is going up and down, if we're seeing them repeatedly going into hospital in the same year, that would be a little red flag to us. So you might go, actually, they've been in 3 times already this year. We need to go and review.
And Carly, what is really important is that, as you said, it's about when we're going to do our social care reviews, but also it's about avoiding that abrupt transition, isn't it, into another service. So we get lots and lots of calls from social work practitioners where actually they are kind of almost missing that opportunity to get somebody into care that is accessible, being funded through health, such as a fast track. We have many social workers saying, well, they need a fast track today, and actually they may well have potentially identified that much earlier on, because what we're hearing from the community is from the doctors and the district nurses, they're not able to drop everything immediately to respond. And often you'll find, because somebody's already got care, a doctor isn't going to care whether it's funded by social care or whether it's funded by health. And the other thing that we know is that if somebody is eligible to fast track, the care that is available potentially looks very different from what is available from the local authority. So we're talking about things like living carers and much more, and right up until the last few days, maybe even waking nights as well, if that's needed. And I think it's also about understanding, what does this mean for the unpaid carer? And in the hospice, we do a slightly different carer conversation to the one that we do in the community, that is very much about the carer's understanding of the what does this disease mean to this person? What is the end likely to look like? It's kind of much more acknowledging, actually, we're talking about an unpaid carer that is supporting somebody with this life-limiting condition. And as you said, just looking at some of these lines, especially organ failure, we have carers that literally put their lives on hold, don't we, Carly? And we often think we have no idea how they've been able to do that. And it's about how, as practitioners, can we better respond? And certainly when Sharon goes on to talk about her experience as an unpaid carer, we'll kind of get a better understanding from her perspective.
I think you're right. We want to be proactive and not reactive. We want to be able to have timely conversations, and we need to make sure the person is getting the right care at the right time in the place that they choose. So, absolutely.
And also in terms of, this tells us something, doesn't it, Carly, about that pre-bereavement, which we often see with the organ failure, that sense of having said goodbye so many times, and understanding actually, and especially with sudden death, actually how that bereavement process may look much more complicated. So
Yeah.
this is all relevant information and things that is really helpful for a practitioner to have in their toolbox. If we go on to the next slide. So how do we bring this learning into work? And it's about understanding what is the most important thing to the person with the life-limiting condition, but also those close to them as well, the unpaid carer, the extended family, the children. If we're working in adult social care, actually, do we need to open up lines of communication with our colleagues in children's services? It's about creating the space for emotionally honest conversation. So I've sometimes been guilty of thinking that I can literally parachute in and out of having this conversation. And it really is giving people the time and the space in order to be able to share with you how they feel. And Carly, you talked something about, it's about having respect. It's an absolute privilege, isn't it, for us to be able to walk alongside the people that we support. And
Absolutely.
and working collaboratively across teams. So I'm really fortunate that as a palliative social worker, I'm part of a multidisciplinary team that I sit within. So we're talking about consultants, doctors, nurses, healthcare assistants, therapists, occupational therapy, physiotherapists, and that's not an exhaustive list. And being mindful that actually for many social care practitioners, you're working in isolation. So as Carly said, it's really important that you get to know your local hospice. We are supporting so many people in the community, and actually we're supporting many people that are known to social care, and I think there's this myth almost that, Carly, isn't there, Carly, that you have to be dying in order to be able to access our services. And many of the people that come onto our inpatient unit come in for symptom control. That's part of their journey, isn't it?
Yeah. And we always get the comment, I wish I'd known about this earlier. I wish I'd have known about this service earlier. And as I say, we like to be proactive and not reactive. We could do so much more with people earlier on in their journey, and then we may not see them for a few months. We may not see them, and they're going off living their life, which is amazing and exactly what we want them to do. And then we may never hear from them again, but we may, and we'll pick them up and support them. And we have various teams that can pick them up and support them at different points. And also, as healthcare professional in a hospice, we're there to support our colleagues out there in the communities as well, to look after we can't support everybody that's dying. So actually we are there as a support for healthcare professionals and social care practitioners.
And it's about how we reflect on the practice that we do. And I think certainly being part of a multidisciplinary team, I would say, from the moment I walk in to work every day to the moment I leave, actually, aren't we engaged in that reflective practice throughout the day? And things can be very unpredictable and can change very quickly.
Mm.
Next slide, please. So this is where we would like to bring in Sharon, who has very kindly agreed to talk about her experience of being an unpaid carer. Thank you, Sharon.
Thank you, Alex and Carly. I want to share with you briefly, I could talk for hours about this, but I know I've not got much time, my experience of being a carer for my frail elderly parents. And I know many of you on the call are likely to also have frail elderly parents or people in your families or people you love who you're caring for. So just kind of a reminder about that warning to take care of yourselves as you listen to what I say. Perhaps you could flip back to the previous slide, please, because I want to just talk through that in terms of my experience. So prioritising what matters most to the person and those close to them. The issue with my mum and dad is that my mum was diagnosed with Alzheimer's disease in 2014. She was living at home with my dad. They'd been married forever. And dad was caring for her, and we were all sort of mogging along okay. And then in, I think, 2017, my dad was diagnosed with non-Hodgkin's lymphoma. And I was scared because I just thought, oh my God, what are we going to do with mum if dad dies? And how's he going to cope with this treatment? But actually, the good news is he coped with the treatment remarkably well. He was 80 years old at that time, and he recovered. But it did have that impact on him. He did not return to his baseline, and he started to deteriorate from that point. My dad had taken out an advance directive years ago in which he said under no circumstances whatsoever were my sister and I ever to put him in a care home. And this was because my dad had been, for part of his life, a Methodist minister. And he'd obviously been and visited people in his parish, or whatever you call it, who were in care homes, and sadly had seen the good, the bad and the ugly. And we all know it's there. I do just want to say, as a social worker myself and as the former Chief Executive of Skills for Care, I know there's far more good than bad out there. And my parents did eventually end up in a brilliant nursing home. But when it's bad, the impact for people is devastating. So after dad's cancer treatment, I suggested to him that we got carers in to start helping him and mum to really try and get my mum used to the idea of other people being in her home. She was queen of that castle, believe me, and her mantra was, I keep a beautiful house. She had been incredibly house proud, but not only did she have dementia, she's got terrible cataracts, which she wouldn't accept because there's nothing wrong with her. So she's blind now, and she couldn't see that the house was not as she thought it was and wanted it to be. So we gently persuaded her to allow us to get a cleaner in. The cleaner was actually from a very good care agency, and this was all about building a relationship, which worked because as my mum and dad's health deteriorated and their needs increased, my dad's mobility really became a problem, and he was weak and he was just, he was going downhill. So we upped the care to the point where we had the carers going in every day to ensure mum and dad were taking their medication and having something to eat. I should say my parents live in Derby, my sister lives in Derby, I live in Cambridge, so it's a 2-hour drive for me to get there. And part of this decline was various hospital stays for my dad because he kept falling, and that meant that my sister and I had to go and be with our mum because she could not be left on her own. She just wasn't safe. And actually going and living with my mum for a couple of weeks and caring for her was one of the hardest things I've ever done, because she was so distressed and disoriented without my dad. It was also the first time that she didn't know who I was. So she came into the bedroom where I was sleeping and said to me, could you tell me where my husband is, please? And I said, Mum, he's in hospital. Dad's in hospital. She said, oh, and who are you? That's not a good moment. I'm used to it now. That was a couple of years ago, but it was tough. So eventually we got to the point where I'm just keeping an eye on time. Tell me wave at me if I'm taking too long. We got to the point where...
Fine. Absolutely
okay,
fine.
Thank you. We got to the point where Dad had been in hospital. We'd been going through all this cycle again, and this is so emotionally draining as well as physically exhausting. I had come home after getting Dad out of hospital, and I got a phone call in the afternoon the next day from the neighbour to say he'd fallen again and he'd hit his head. So I called the care agency. They went back in, got him back into bed. 2 hours later, the neighbour called me again, pretty peed off by this point because he'd fallen again. I had to get back in my car and drive back up to Derby to be with him and mum because my sister had something happening that weekend that she couldn't rearrange. There was no choice. I had to do it. And it was dreadful. And we had a terrible night. I thought my dad was going to die. That thing Carly talked about, you know, you called. I've been called to my mum and dad probably 6 times between the two of them now to be told they're at the end of their life. And my mum is, she's indestructible. She's going to go on forever, I think. My dad has sadly now died. We'll come back to that. So in the morning, I had to say to him, Dad, we've reached the point where you and Mum need 24-hour care. We cannot go on like this any longer. And there are 2 options. Either you have someone move in here with you, which we all know is going to be really difficult, especially for Mum, or you go into residential care. And he opted for live-in care. So I spoke with the care agency, who are not a living care agency, but because they'd been working with my mum and dad for about 7 years by this point, they were very fond of them. They were very good. They organised a living carer for us. I contacted social services and social workers came out to assess my mum and dad. So, and I'll just say at this point, unfortunately, due to Mum's dementia, and she was by this point experiencing hallucinations and agitation, she was getting the carer up all the time. That first package broke down and I had to very quickly find another care provider to come in and provide care for my mum and pay for a waking night, because she just had them up all night long. So you can imagine how much that was costing. I'm not saying it's expensive, by the way. I don't think it is expensive. It's a costly service because it's 24/7, but some people need it, and my mum's one of them. So creating space for emotionally honest conversations, I'd say my experience here was mixed. The social workers who came out were very empathetic and they understood and they were respectful, but the system is not. I understand why it was necessary to allocate an individual social worker to my mum and my dad. They're both people who need their needs assessing, but they've been married for 65 years at that point. My mum is totally dependent on my dad, and doing it that way, they couldn't organise themselves to come on the same day. So I had to take 2 separate days off work to go and be there for those social work assessments. That is not emotionally honest as far as I'm concerned. We did have a really good experience later on when we were put in contact with the Derbyshire Palliative Care Dementia team, and they were brilliant. They listened, they understood, they knew that because of the experiences we'd had, my sister and I, and my dad, who was still with us at that point, were adamant that unless my mum had a broken bone or pain that could not be controlled in the community, she was never to be admitted to hospital again. That's a whole other story we haven't got time for, but there we are. So working collaboratively, this is so important. And if I can make one plea to you, please, whoever you are on this call, please work with, not against, your colleagues in other settings and other sectors. The disconnect between care and health is as strong and alive today as it was 40 years ago when I started practicing, which is such a shame for practitioners caught up in it. It's heartbreaking for families caught up in it. And the worst example of this for me is the continuing healthcare framework, or rather the way it's implemented. I applied for continuing healthcare for my mum in September 2023. We then had to wait for the mental health services to come in and optimise her through medication. A DST was completed in February 2024 without my knowledge, without my input. It was submitted. I was told then that it had been submitted. I rang in May to find out what the answer was, to be told it had been lost. And we had to do the whole thing again. So this time they did involve me. It took until September 2024 for a decision to be made, by which time I'd had to move my mum and dad into residential care because their money had run out. We were turned down, but awarded funded nursing care, which meant I had to move my mum and dad because they had to move into nursing care. They also had to move into nursing care because exactly what we had predicted would happen, happened. Because my mum didn't have one-to-one support and observation in the care home, because that's not what they do, she fell. and she sustained a brain injury, from which, of course, she has never recovered. Offering proactive support to families and unpaid carers. I'm sorry to say again, my experience here has been absolutely no proactivity. It's been me having to chase people all the time for answers, having to suggest things, having to ask what's happening, when's this going to happen? And again, a terrible example of this was the last time my mum was in hospital following that brain injury, where the hospital in Derby were planning to do discharge to assess. The ICB from the previous county, I won't name, said, no, we assessed her 3 months ago, there's no change, don't do a discharge to assess. There'd just been a brain injury, that's all. So I'd also just kind of add in, I work full time, and the time that I needed to be chasing all these people I shouldn't have had to chase was the time I was at work trying to do a full-on, full-time job. So we need to think about that as well, about accessibility and how we can make it easier for people who need to speak to us. And then thinking about reflecting on our own practice. If we do these other things that we've talked about, and there are examples of good things happening, but sadly too many, exactly, awful examples, then we can reflect on our practice and think, yes, we have done the best we can. We can't make a really challenged system perfect, but it could be so much better than it is. And I say all this to you as a qualified social worker and registrant with Social Work England myself, and as you know, chief executive of the hospice. And one of the things that's broken my heart the most through all of this is that if I can't find answers and I am having the most hellish battle in my life, what hope for people who don't have my knowledge, my confidence, my amazing colleagues who've supported me? We have to do better.
Thank you, Sharon. And that's in part why we're here today. And Carly and I, we've been working closely together in recognition that many practitioners feel they don't have the competency or the confidence to support people with a life-limiting condition, and especially their unpaid carers. And we recognise that this isn't necessarily a big part of social care training. So with Carly, we've gone in together to the universities, haven't we, at a grassroots level to open up these conversations. And that's something that I do on a regular basis to provide some training.
Thank you. First of all, can I just say that definitely the Q&A function has been very busy, and I would like, because we have just 5 minutes left, I would like to share some of the feedback coming through. I think it's really important to hear that, and we'll address some questions as well. First of all, I'll start with Sharon. Sharon, we have a brilliant presentation. Sharon, thanks so much for being so honest. We are also struggling with continuing healthcare and DST so much. I can identify with you. Carly, direct feedback for you. They're saying brilliant presentation, and all of you, by the way, Alex as well. Enjoy your presentation approach. You are such a spontaneous, you are a natural. Therefore, please join us in the future as well. Carly is a registered nurse. Now we have lots of other feedback. One of the questions, I'm going now to move to questions if that is okay, and I'm going to let you decide which one of you might want to take that question. I'm so sorry, the sun definitely decided to come through. If you can recommend any tips for social worker, for any social workers who might consider maybe working in this area of social practice, do you have any tips? That's one of the questions. Let's start to look at that, and then we move to the following ones.
In response to that, so in the hospice, this is the second year that I've had a social work student. So I think it's about very early on trying to get your foot in the door. The jobs, unfortunately, are few and far between. I'm the only social worker, I can't remember if I said, in the whole of Cambridgeshire County Council. And there absolutely is a need for more than one of me in the county. Sharon, if you would like to add something to that.
Yeah, I mean, there is an association of palliative care social workers who you can contact, and they do run courses and conferences. And I think, as Alex says, the opportunity for paid work, unfortunately, is quite limited. I think that's because there isn't sufficient emphasis on the role of social work in hospices, and so we are trying to promote that, but you know, lend your firepower to that. And also just to say thank you very much for your feedback, and to whoever who's going through CHC, I am with you.
Thank you. Another question, this is direct, and if anything, Alex and Sharon and Carly, you have definitely made people think, professionally curious about this. Do you have any books, recommendation or resources I can access now? I'm a hospital social worker. I'm keen to learn more about the hospice social work. How would you recommend gain more experience in the field of social work? And I think, Sharon, you kind of touch on that. Is anything else you would like to add?
So the book that immediately springs to my mind, or two books actually that I would recommend, are Catherine Mannix, With the End in Mind, and I think the second book is called Tender Conversations. But they're excellent books, just helping you. She talks about her experience as a palliative care consultant. She's a wonderful communicator. There are lots of books. I'm sure we could send a list through of books that perhaps could be shared with colleagues afterwards.
Right, thank you. And we still have a few others. I'm also mindful we have 2 minutes to go. And I just want to say, finally, a feedback from one of the participants in this session today, which was, in my own view as a registered social worker, definitely not just insightful, also a very powerful session. Thank you so much to 3 of you. One of the social workers said, I also want to say that I was a palliative social worker for 10 years, loved my job, met some wonderful patients and their families, and had some laughs too with them, but of course the sad experiences too. I want to say that on this note, I'm going to say we are more than happy, isn't it, Alex and Carly and Sharon, you have shared the email address earlier. The presentation can be also shared. The recording is going to be available in a couple of days or weeks. Once again, a big thank you to the 3 of you for joining us today and for giving your precious time to share your expertise and experience with all the participants, in fact beyond that, hopefully with more people in England. But also thank you to all the attendees joining us, to the participants for allocating time. We know how busy you are, and we hope you enjoyed this session and you find so much information and a lot of insight around this. Please do complete the survey, the feedback form, which is available in our chat. I think my colleague Chloe has posted that. And we hope that you are going to give us feedback, what we can improve, what we can do different going forward. I want also to remind yourself that this is an opportunity for a fantastic continuous professional development reflection. You have heard really powerful statements and direct experience from Sharon. Thank you so much once again, Sharon, from my side, for sharing your personal experience. So definitely a really tough time from what you described, navigating the system of social care and health system. Thank you from our side for joining us today in that role. Thank you, everyone, and have a lovely rest of that day. Hopefully, we're going to see you tomorrow. We still have 4 sessions happening tomorrow, part of Social Work Week, and thanks you once again. Goodbye.